with Dr. Dunn. Today, I'll be sharing research findings regarding the book questionnaire, the Brief Opioid Overdose Intervention that was developed alongside the questionnaire. But first, I'm going to provide some background on the opioid epidemic and provide information on screening, brief intervention, and referral to treatment. So most of you are familiar with the scope of the opioid epidemic. Currently, approximately 91 opioid overdoses occur each day in the United States. Drug poisonings are the leading cause of death in persons aged 25 to 64. And over 12 million people in the United States report misusing an opioid such as a prescription pain reliever or heroin. Over a quarter of primary care patients with non-cancer pain suffer from an opioid use disorder. Yet many of these individuals, in fact, the vast majority of individuals with drug use disorder did not receive treatment, and even most of them don't perceive a need for treatment. So these are clearly obstacles that we are looking to overcome. For the first time in over half a century, life expectancy has declined in the United States for 2 years in a row. This is largely due to the opioid epidemic. Of particular concern, the death rate of people between the ages of 25 and 34 increased by 10% between 2015 and 2016. This trend is unusual and is unanticipated, and is occurring at the same time that death rates from heart disease, cancer, and injury-related causes have declined. So we're doing some great work public health-wise on heart disease and cancer, but the opioid epidemic has overtaken some of the advances that we have made in those areas, and young individuals in the United States are dying at rates that are unseen before. Opioid overdose deaths is a complex and evolving problem. Deaths involving any opioid have been increasing for almost 20 years now. In 1994, the age-adjusted death overdose rate was 4.8 deaths per 100,000 people, which this slide doesn't go back to 1994. By 2015, the rate had more than tripled to 16.3 per 100,000. And since then, overdose death rates have continued to climb. In 2016, data shows that overdose death rate reached 19.8 deaths per 100,000, more than quadrupling since 1994. Opioid overdoses were initially largely fueled by prescription opioids. In the past 4 years, we've seen a sharp rise in heroin and synthetic opioids. The age-adjusted rate of drug overdose deaths involving synthetic opioids, other than methadone, such as fentanyl analogs, and tramadol, has doubled between 2015 and 2016, from 3.1 to 6.2 per 100,000. Yet prescription opioids, shown here as natural and semi-synthetic opioids, continue to contribute to a significant number of opioid overdose deaths. And you can see this trend displayed. It just continues to rise. We've had some changes here with synthetic opioids overtaking the natural and semi-synthetic opioids in the last several years. But it's a troubling trend that these substances are really causing significant death in our communities. Before the current epidemic, overdoses were attributed to heroin use. Then we began seeing overdoses among people with severe or chronic pain. Today, all segments of society are experiencing opioid overdoses. And we know that opioid access is the leading cause. Older adults are affected, military members are affected. Veterans, in fact, are twice as likely as non-veterans to die from accidental overdoses of painkillers. And among persons aged 15 and older, adults aged 25 to 54 had the highest rates of drug overdose deaths in 2016. These individuals are often raising children, and therefore entire family systems are being negatively affected by this crisis. So why is this happening? In the late 90s, we experienced changes in how the healthcare field and patients viewed pain. At this time, working from inaccurate information, physicians began prescribing opioids for pain at much higher rates, and they believed that there were few negative consequences to these prescription drugs. This led to more opioid misuse and ultimately more opioid-related consequences. As this graphic displays, the more access to opioids, the more likely a person is going to develop an opioid problem. So as you see, as the days of the supply go on, the likelihood that someone will experience an opioid-related problem increases. So this is the 1-year probability line. This is the 3-year probability line. And as the days of supply continues, that probability of opioid problems increases. Despite this, and our continued concerns about opioid use disorders and overdoses, the number of opioid prescriptions in the United States remains too high. There are a variety of limitations with our current practice. So while we have more patients prescribed opioids for pain, the healthcare field is not more prepared to deal with misuse and opioid disorders. Less than half of primary care patients who are now in substance use treatment reported that their physician addressed their substance abuse. So these individuals are getting into treatment one way or another, but it's often not because their primary care physician has discussed their substance use with them. And physicians don't feel prepared to identify or intervene with alcohol and drug dependence. Many patients who are prescribed opioids are not informed of their opioid overdose risks. In fact, many do not even know that their drug they are taking is an opioid. Physicians simply aren't kind of alerting patients to the fact that when they're making a prescription, that the prescription that might have a brand name is an opioid. So, and there are no necessary warning labels on those drugs or things to alert patients to know that what they're taking is even an opioid and something that they need to be alert to. So as a result, patients who are prescribed opioids are not informed of their risks. So we believe that SBIRT, screening, brief intervention, or referral to treatment, is part of the solution. Both the Clinton Foundation and the President's current Commission on the Opioid Epidemic have included SBIRT as potential strategies that can be used. So screening, brief intervention, and referral to treatment, or SBIRT, is an effective public health strategy that can be used to identify and appropriately intervene with individuals who are at risk of substance use dependence. When combined with community-level prevention strategies, SBIRT contributes to prevention of disease, injury, death, and other negative consequences of alcohol and drug misuse in individuals, families, and communities. We have 30 years of research that demonstrates the effectiveness of SBIRT. And very importantly, the research is ongoing, but initial evidence suggests that SBIRT is effective specifically with opioid users. SBIRT's a 3-step process. You start with a screen, preferably a universal screen, and the screen, while often is done in primary care practice, it can also be completed in ERs or schools, college campuses, etc. So if you do a universal screen using a validated tool, at WellScreen, we like the CRAFT for adolescents, and we like the ASSIST for adults. The reason we like the ASSIST is that it specifically asks about multiple drugs. It's not specific to just alcohol or just illicit drug use. It includes multiple drugs, and you can identify steps for those individuals. So most individuals who are screened will score low risk and receive positive reinforcement. In fact, approximately 70% of those who are screened will identify as abstainers or low-risk users. Screening results may signal the need for follow-up by the practitioner. So approximately 20 to 25% of the population will screen as moderate risk. In these cases where the person has identified at some risk, the practitioner should provide a brief intervention. The highest score screens, usually among 5% of the population, will signal a need for a referral for further assessment and treatment. What's important to note is that the primary goal of SBIRT is not to identify alcohol and drug dependent individuals. While SBIRT will identify those individuals, but the primary goal is to identify and intervene when there are signs of risky use. So before there's a dependency, but while someone is using a substance at a risky level. The research shows that by intervening early with individuals at moderate risk, we can reduce substance use and prevent health and other related consequences. And this intervention is simply that brief intervention. So we can, by identifying these individuals and then providing a brief 15-minute intervention, the research supports the fact that those individuals often then move into low-risk use patterns and are not in need of additional intervention. So the SBIRT protocol can be used in various locations like primary care and emergency room, as well as schools and community settings. Not only is SBIRT a research-based strategy, it's one of the most cost-effective strategies available. Research shows that SBIRT can return over $20 for every $1 invested. And the National Commission on Prevention Priorities said that alcohol screening intervention provides the fourth greatest risk return on medical investment, behind only aspirin, childhood immunizations, and tobacco cessation. So at WellScreen, in order to address the opioid epidemic, we're combining SBIRT with BOOK, the Brief Opioid Overdose Knowledge Questionnaire. So now I'm going to go over why BOOK was developed by the research team, and then what the research team found regarding BOOK. Once they had developed the screener questionnaire, they then developed an educational intervention. And so we're going to go over the results of that research as well. So the book, as I've mentioned, is the Brief Opioid Overdose Knowledge Questionnaire, and it was developed by Dr. Kelly Dunn at Johns Hopkins University with funding from the National Institute on Drug Abuse. They were really looking to fill a gap in knowledge and in screeners for this population. What they found when they were looking at what was currently on the market and what had been researched is that there were current risk measures available, but they were designed to measure the likelihood of abuse. So these risk assessments are looking for the likelihood of abuse, and they rely on the patient's reporting of past and current abuse. Other overdose-specific measures are focused on overdose response. So these measures are looking at does the population understand how to respond to an opioid overdose, not necessarily how to prevent or what the risk factors for overdose were. They also found there was no general knowledge-based measures available, and the measures that might have been available were either focused really on pain, folks who are using substances for pain, or illicit populations, but not a screener that would work for both pain and illicit populations. So their goal was to really look at developing a screener that was short and that could be generalizable across populations for both illicit and pain patients. In addition, available overdose resources focus heavily on naloxone or Narcan administration. Community-based programs have been largely effective at distributing naloxone. So there are many advantages to Narcan. Most importantly, it is out there saving lives. But Narcan also has some disadvantages. A key point is that Narcan is for opioid overdose reversal, not opioid overdose prevention. Therefore, individuals, communities, and states are in need of evidence-based prevention and early intervention resources. Additionally, naloxone distribution programs rarely target chronic pain patients. We've seen that most of the Narcan that is available is going to individuals who have recently overdosed, individuals who have an opioid use disorder, or people who are in the lives of people who are likely to overdose, so laypersons who might be in a position to witness an overdose. So there is this high-risk population that is not currently addressed with evidence-based tools for prevention, early intervention, or overdose prevention. So the research team's goal was to develop a brief and validated method to enable providers to quickly assess general knowledge gaps in patients, and then customize brief interventions for opioid overdose risk, something similar to SBIRT. So the research was conducted in 3 phases. They started with illicit opioid users in Baltimore, and then they took 59 self-report questions, and they used this population to narrow it down to a 12-question screener. In phase 2, they took those 12 questions and looked at illicit opioid users in both a rural setting in Vermont and an urban setting in Maryland. Again, that population is in Baltimore. Phase 3 included patients currently prescribed opioids for the treatment of chronic pain. And these patients were recruited from across the United States and were representative of a large population within the country. They also used phase 3 to validate those 12 question samples. So looking at those populations, they've got the illicit user sample 1, illicit user sample 2, and sample 3. Among those populations, a third of illicit users had experienced a non-fatal overdose on opioids. And nearly 20% of the chronic pain population had also experienced a non-fatal overdose on opioids. Over 2/3 of the population, or nearly 2/3 of the population, witnessed an overdose in sample 1. There was less individuals in the chronic pain sample who had witnessed an overdose, but we're still talking about over a third of these patients had witnessed some type of overdose. So the research team narrowed down the questions from 59, and the resulting measure has 12 true, false, and then I don't know. These questions should be familiar to you if you logged in early. We had you all take the book. So there are 12 questions, true and false, that you all have likely already answered. So we're going to take a look at that survey. I'm going to share those results, I hope, with you all. And so here are the questions for the book. Questions about how long-acting opioids are used, whether or not methadone is a long-acting opioid, what are symptoms of opioid withdrawal. So all of you got question 3 correct. Here are examples of opioids. Again, everyone got question 4 correct. Another example of trouble breathing is not related to opioid overdose, so this is the risk of opioid overdose. The answer there is false. Another question related to the signs of opioid overdose, the fact that all overdoses are fatal, the answer there is false. And then they go on to look at the risk factors of opioids and opioid response. So those are the 12 questions in the book. Everyone got question 12 correct as well. So ultimately, there are 12 items. They are true, false. The first 4 items are assessing general knowledge. So like I showed you the long versus short-acting drugs and what are some of the withdrawal signs. The second set of questions is looking at opioid overdose risk knowledge. And then finally, overdose response knowledge. That's items 9 through 12. The purpose of including I don't know as a choice is to discourage random guessing and reduce the chance that participants will accidentally answer the item correctly. So we're really looking to identify what the participants' true knowledge is so that we can intervene in ways that are responsive to their particular knowledge. So as I mentioned, they developed this 12-question scale with the patients in phase 1, and then they validated the screen in patients in phase 2 and phase 3. So they have used this among illicit and licit or pain patients, and they've used it among rural and urban populations. So I found the research results to be quite fascinating. Patients receiving opioids for pain management knew less about their opioid overdose risk than licit users. So particularly here around general opioid knowledge, the illicit users answered many more questions correctly, compared to the chronic pain patients, and then also among opioid overdose response. They were getting fewer answers correct. So while we know that this population is at risk for overdose, their knowledge, there are significant gaps in knowledge. In addition, 22% of this population, those are the pain patients, reported misuse of opioids in the past month. So again, this is a high-risk population that does lack knowledge about the substances that they're using. Importantly, the mean number of correct items across both populations was 50% or lower. So most people were not getting above a 50 when they were taking the book screen, knowledge screen. The research team then looked at the specific questions, who was answering them correctly or incorrectly, illicit users compared to pain patients. And again, we found here that the pain patients were scoring lower. They were not getting as many correct. But we did not see a difference between the rural and the urban population. So those who were in the rural population in Vermont compared to those who were taking this in Baltimore, as well as then the pain patients across the country, they looked at them rural versus urban, and they did not see a significant difference in their knowledge based on their demographics. So the primary driver was whether or not they were illicitly pain patients or if they were illegally using opioids. And so this illuminates an important opportunity for intervention. Let's look a little further about how risky chronic pain patients actually are. So you'll see here that pain patients had a higher rate of lifetime overdose, and these would be non-fatal overdoses, of course. So they had a higher rate of overdoses. They were overdosing on prescription opioids at higher rates. Nearly, if they had experienced an overdose, 80% of them had been using prescription opioids. And they had some additional risk factors like using opioids alone. Fewer were, but still a third of them were combining opioids with alcohol. So we were really identified that this is a high-risk population. Furthermore, as I mentioned earlier, most of the Narcan distribution has been focused on the illicit user, and it has not been focused on the chronic pain user. And so it's not surprising that we're finding that this population of chronic pain patients does not have the same access to naloxone. So they don't have a prescription for naloxone. They're not trained to deliver naloxone, yet they are trained to deliver CPR at about the same rate as those who are illicit users. So then the question is, what can be done? With this information about the population at risk, they began developing an educational intervention to address the gaps in knowledge. They had identified that previous educational interventions were, first, they weren't adequately studied and evaluated in randomized trials, and they often were growing out of response to heroin use. So most of the educational components targeted illicit drug users versus pain patients. They required trained professionals to deliver the intervention, and many of them were really looking for outcomes related to naloxone administration. So some of the educational interventions, they would provide education related to naloxone administration and then identify if there had been an increase in knowledge around naloxone administration, which isn't really a general education component. So we know that there's a much larger population of individuals who are prescribed opioids for pain management who are at risk of overdose, as we've identified in the previous studies, but do not have an opioid use disorder. So they looked to develop an education tool that could be used with both illicit users as well as patients prescribed opioids for pain. So they began testing an educational intervention with individuals who had been released from outpatient detox, And they randomized these patients into 3 different groups. They provided pamphlets of information. So this was just a paper with information about opioids and opioid overdose risks. Then they did a computer intervention that simply allowed the individual to watch an education intervention. And then finally, they did a computer intervention with questions. So as the individual went through the education intervention, they asked questions to try and assess whether or not, as they were moving through the education component, they were absorbing the information and learning about what they needed to learn. They used the book to assess pre and post-test knowledge. And not only did they do the pre-test, but then they completed a 1-month and a 3-month follow-up to determine whether knowledge was sustained over time. Here's an example of the intervention. So it has a question about what are opioids, and then it gives general information about the fact that opioids are natural pain-killing substances. They work on the pain system. They give examples of opioids. And then here's a question that they ask. So what kind of drug is heroin? The information was provided. Can the participant answer that question correctly? So this is an example of the online intervention with the question response. And so what they found is that all 3 interventions did lead to an increase in opioid knowledge and opioid OD knowledge and opioid overdose response knowledge. They found that the computer intervention and the computer plus questions intervention had a higher effectiveness. So you were seeing a greater increase in knowledge between time 1 and time 2 among those individuals who had received the computer intervention. They also looked at what was the response by the participants. Did they find that the intervention was easy to understand, etc. So what they found is that the overall, the computer and the computer plus questions was very easy to understand. 100% of the participants in the computer found that it was easy to understand. Also importantly, 100% of those who received the computer and computer plus intervention believe that the intervention will help prevent them from overdosing in the future. And 100% of all of the participants across all 3 methods would recommend the intervention to family member or friend. So this was well-received intervention by the participants. So what they then, kind of the conclusions they received related to the illicit users is that they had relatively high baseline knowledge of opioids and opioid overdose risk. As we had mentioned in their previous studies, they'd identified that pain patients are going to have a lower baseline of opioid knowledge. All 3 interventions had significant gains in knowledge overdose response, and all of those gains were sustained in groups out to 3 months. And as we mentioned, the gains were highest among the computerized groups. The computer-only version without the questions took an average of 18 minutes to complete. And it should be noted that this computerized version was taken remotely. So they were given a link and they were able to watch it remotely. So there was no human intervention here. This was simply them looking and watching the intervention on a computer and then responding to questions there. And 100% of participants would recommend to a family or friend. So once they had developed this intervention with the illicit users, again, they wanted to make sure that this intervention would work for individuals who are prescribed opioids for pain. We know that individuals with chronic pain are more likely to be engaged in ongoing medical care. And so therefore, standardized intervention could be used to reach out to this population in a way that's consistent and effective across users. For this study, participants were randomly assigned to the presentation intervention or the intervention plus mastery. So they did not include the pamphlets in this intervention because they identified that the computer intervention was much more effective. The group receiving the presentation plus mastery intervention was provided corrective feedback. So as they answered questions, they would listen to it, they would answer a question. If they answered a question wrong, they would get corrective feedback, and they wouldn't be able to continue in the educational module until they had demonstrated mastery of the various topics. The group receiving, both versions of the intervention resulted in significant increases in book scores across all knowledge domains without significant differences between the groups. So here you see opioid knowledge increased again with the computerized version as well as the computer with the mastery. Overdose knowledge increases, response knowledge increases, and there's a dramatic decrease in the number of individuals who answer "I don't know" to one or more of the questions. So changes in pre and post-test scores for the book were examined to determine the changes in knowledge, and we saw significant gains in all three domains. They also looked at the intervention and how well it was received by the participants. And most participants rated both the interventions, the mastery, and the computer very highly. So nearly 90% or over 90% found that these interventions were easy to understand. Very few of them found that it was confusing. And once again, almost 90% of those who receive this intervention believe the intervention will prevent them from overdosing in the future. So this is an important measure of effectiveness. And then many of them, again, over 90% of them, would recommend the intervention to a family or a friend. So with the conclusions drawn from the second study are that the patients receiving opioids for pain management had relatively low baseline knowledge. They had lower knowledge than those who were illicitly using opioids. But they showed that they could increase significantly their knowledge after that brief intervention of the knowledge education, computerized education module. 93% of these individuals would recommend this to a family or friend. And the computer-only version took an average of 21.5 minutes to complete. To provide a few more details about the education module, there were 4 modules as part of this. So the module 1 focused on a basic understanding of opioids, identifying what drugs are considered opioids, what are the effects of opioids, that type of thing. Module 2 looks at the risk factors for opioid overdose, things like using opioids alone, using them for significant amounts of time, using them with other substances. Module 3 went into the symptoms of opioid overdose. And then Module 4 talked about if someone was overdosing on opioids, what the individual could do. So that's the opioid overdose response. So the participants could complete all 4 modules in approximately 20 minutes. So Dr. Gunn's research found that the book quickly screens individuals to assess their opioid knowledge and, importantly, doesn't require clinician training or content knowledge to administer. You can administer the screen as an individual, and you can do it remotely, you can do it on a tablet. There's no reason that a clinician needs to be trained in how to administer the book questionnaire. The items in the book pertain to all opioid users and therefore can be used across settings, such as primary care, chronic pain providers, emergency rooms, even used in jails or prisons and schools. So you can quickly identify individuals and knowledge gaps among individuals who are using opioids for chronic pain. Additionally, the brief educational interventions were informative and produced sustained knowledge gains across all of the different scales. So a low Brooks score can effectively be addressed with this web-based education module, and it has been studied across the different populations. So currently, the only widely available approach for opioid overdose is the distribution of naloxone to high-risk populations. But as mentioned earlier, opioid overdose reversal is an important tool for saving lives, but is not a prevention or early intervention strategy. So a public health response proportional to the opioid epidemic requires smart and scalable approaches. WellScreen has integrated book with SBIRT tools to provide a system that allows practitioners to assess for risky substance use and identify gaps in knowledge. So using our screen, our tool, we have integrated Assist with the book. So if a practitioner screens using the Assist screener will identify someone who is perhaps a non-dependent high-risk user. But if the patient indicates that they have used opioids in the last 30 days, the system will complete the Assist screen so you can make sure you identify their risk, but then take the practitioner and the patient into the book screen. So then if you have a patient you know is using opioids currently, or at least in the last 3 months, you can then do a knowledge assessment to identify whether or not they have a gap in knowledge related to the substances that you know they're already using. So the screen generally takes about 10 minutes, and the system will provide an immediate report of results for the patient and practitioner. It will give you a risk assessment, not just for opioids, but for all substances, alcohol, tobacco, and other substances, including opioids, and it will give you a book score. So those two scores combined give the practitioner very solid information to move forward into the education and intervention. We are now working with Dr. Dunn to integrate the evidence-based education module into our screener. So if someone scores low on the book, it's a failing score, 70% or below, the practitioner can provide that evidence-based education module to increase the knowledge of opioid overdose risk and opioid overdose response. Again, that education module will take 20 minutes, can be completed remotely, and it can be completed within the same intervention right after they get the book assessment. In addition, the system, again, wants to respond to the risk. So if someone is at risk of not only opioid misuse or overdose, but any risk for substance use, the system will prompt the practitioner to assist with a brief intervention, and then, if necessary, it will help connect that individual with treatment resources. We're working with the National Association of Addiction Treatment Providers to ensure that our system has only credible, licensed, accredited private treatment facilities, and then we're using patient matching, such as the demographics and zip code of the patient, as well as their sex and what their risk score is, in order to match them with appropriate treatment resources. So within the system, you go from screen to educate and intervene, and then if you need to, you can do a referral to treatment, matching that patient with the most useful treatment resources available. In addition, we have the public database because we want to make sure that individuals who are not using private resources and can't access private treatment facilities also have access to resources. So we're using the SAMHSA treatment finder for the public resources, and then our relationship with the National Association of Addiction Treatment Providers to identify the private resources, so that, again, we're making sure that we're connecting individuals with only the best treatment resources available based on them. Finally, the system recommends a 60-day follow-up screen and provides a comparison to the initial screening results for that particular patient. WellScreen goes from the assess and identify, but for health systems and communities, one of the great things that the system will offer is aggregated reports and analytics. So at the patient level, you'll get a report for that particular patient, and it will help drive you to the right next steps for that patient. But at the community or practice level, you can identify what are the substance use trends that are happening within your community or in your state even. So you can take reports and run reports within our system by zip code and map that information. You can then look at substance use risks and use patterns around alcohol, tobacco, all of the other substances that are included in the assist screen. Those reports, again, are aggregated, so it's not giving you individual level results, but at the community, state, or system level, those results can help with planning your interventions and your policies going forward. Again, at the individual level, you get individualized results. As I mentioned, we have the on-demand educational video and also educational materials to print. So the practitioner is not at a loss as to what to do once they've identified that the individual needs some type of resources or response. And then we have the electronic referrals, this curated database of treatment providers based on the National Association of Addiction Treatment Providers, and we ensure that 60-day follow-up. Furthermore, the system is EHR compatible, so we can work with health systems to integrate the WellScreen system into their EHR and customize it to meet the practice workflow. And so even within a large health practice where you might have various primary care facilities who might choose to use different workflows, you can use one system and vary the workflow based on those different practice requirements, but still aggregate the data up to the larger health system that they might be operating under, so that you can look at reports across health systems, across communities and states, but you can also really customize it to the needs of each individual practice. We have lots of training and support. We really believe in the work that we do, and we're mission focused, so our technical support is all US based and all has a background and passion for substance abuse prevention and treatment. So our system allows practitioners to use a tablet or laptop to conduct screens, provide instant results for the patient and practitioner, and aggregated reports for the health system, community, or state. It assists the practitioner in developing an intervention plan, integrates educational materials, and matches patients with appropriate treatment resources based on location, demographics, and treatment need. So we believe that with the universal implementation of WellScreen, we can help prevent opioid use disorders and overdose. By providing an educational module right when the prescription is written, we can reduce the likelihood that that person will misuse substances. But even still, if you have a patient who has already gotten a prescription and is already misusing, as 12.5 million individuals in the United States are, you can conduct a screen to identify that misuse. You can also conduct the screen to identify gaps in knowledge. You can provide that educational intervention and a brief intervention, and hopefully stop the misuse before that use goes on to dependence. But our system will also work with individuals who are dependent or have developed a substance use disorder. We want to make sure that we identify those individuals before they get to a place where they have overdosed. We want to conduct those screens, provide that education, provide brief interventions, and referral to treatment across systems. Ultimately, our platform is based on the latest research and has the potential to impact the trajectory of patients' lives. So I'd like to thank all of you for participating. I apologize that Dr. Dunn was not here to be a part of this today. If you all have questions about WellScreen or some of the items that I presented today, you're welcome to submit those questions. If I can't answer them because I am not Dr. Dunn, I will make sure that we get answers for you. Otherwise, you can go to wellscreen.health to get additional information about WellScreen or request a demonstration. I'm happy to provide as many resources to help states and communities really tackle this problem in a way that's based on evidence. So we'll leave it open for questions. We've got a few minutes available for that. Oh, the ASSIST screen. So what is the ASSIST? It is the World Health Organization has developed the ASSIST, and I'm not going to remember exactly what ASSIST stands for. It's ASISST. So if you look up World Health Organization ASSIST, it is the screener that they use for alcohol, tobacco, and other substances. And again, it has been validated across different populations and with different languages. So it's one of the screeners that we recommend. There are lots of screeners available. So there's the audit, there's the DAST, there are other screeners that are available that are validated tools that you can use to do the SBIRT screen. Yes, the screening and brief interventions are reimbursable in Florida. In many states, screening and brief intervention is reimbursable by both private insurance, Medicare, and Medicaid. Because insurance is unique to each state, you will need to identify what your rules necessarily are in your state, but most states do allow for reimbursement for both screening and brief interventions, so that's where you get to that return on investment. So again, for every $1 invested in SBIRT protocols, there's a $20 return to the community and the state for that intervention. There are very few other prevention and early intervention resources that have that level of return on investment, much less the level of research that supports the effectiveness. There we are. The question is a copy of the presentation available? We have recorded the presentation, so we will be sending out a recording, a video from us to all of you. So the book is the book available to use. It is copyrighted. So we have a license as WellScreen. Again, we've partnered with Johns Hopkins and Dr. Dunn. And so within our screening tool, within WellScreen, yes, you may use the book, but it is a copyrighted material. So you can't use it without permission outside of our WellScreen tool. Are there any other questions? So how do you access the WellScreen tool? So WellScreen we provide licenses to our tool. So if you contact us at wellscreen.health, we will we can provide a demonstration, and then we can talk about what licenses are for communities and states and health systems. What is the cost? So the cost, the initial annual license for WellScreen is $2,500 is the base license, and that does not include all of the screeners, and then it depends on if you need customization, how many screeners you want, how much, and then also whether or not you need to integrate into the EHR. So each of those different pieces will add to the cost, but the base license begins at $2,500 annually. Are there any additional questions? Do we have marketing materials? Yes, we have marketing materials. In fact, I have a ebook that I will be sending to all of the participants today, as well as, like I said, this recording. And then we have lots of information on our website, which is wellscreen.health. And then I can provide additional marketing materials. So I see this question is from Ellen, and I can contact you directly via email if you'd like. Okay, if there are no other questions, I will go back to the final slide so that you can see our website, wellscreen.health. I hope all of you found the materials that we presented today to be useful and that you can take them back to your communities. Oh, marketing to pain clinics. Yes, we can identify, we can provide marketing materials to you so that you can give those to pain clinics for sure and others within your community. So again, thank you for bearing with me that you did not get Kelly done today. We only wish the best for her and her brand new family. And again, she will continue to be working with us closely, and perhaps we'll be able to offer a live webinar with her the next time. We want to thank all of you for participating today. I know how busy people's lives are, so I appreciate your time. Please go to wellscreen.health where you can get in touch, and then we will be in touch with all of you with a few additional materials so that you can do some follow-up reading and get back with us if you need to. So thanks everyone. Have a fantastic day.